things. First thing, when radiotherapy started way back in 1896, immediately after discovery of X-rays, people, radiobiology forced us to make the more fraction conventional, 30 fractions is a standard, and now the technology has brought us back a large fraction dose delivery. Okay, this is a tribute to one of our colleagues whom we lost just this May. It is Dr. Sanjay Supe, and you all might have felt his absence during the conferences. He was a very active person, a very good radiobiologist, and over and above a human being at par. So this lecture is devoted to this departed soul, Dr. Sanjay Supe, who is good friend of all of us. Now, the practice of medicine, how much has it changed? Doctors are men who prescribe medicine of which they know little, to cure diseases of which they know less, in human beings of whom they know nothing. I am not saying this. Blame, if you want to blame, Voltaire, who has said this long ago. So everything, knowledge we accumulate, and on the base of the knowledge we do. We know very well the first fractionation experiment, and then the Borboni and Riveldo, you know that he gave irradiated the scrotum of the ship and shows that how there's a radiobiology, the cells which are multiplying are more radiosensitive, cells are divided, they are radioresistant, and how we fractionate the radiotherapy to cure the, to attack on the tumor cells and save the normal cells. Now, when you talk about the radiobiology, because as you know, initial era, it was trial and error era of how many fraction, what should be the fraction size, and during 1940-45, the radiobiological models they came in to compare the various fractionation schedules. And radiobiology and radiation oncology, actually the effect on the tumor or effect on the normal tissue depends upon dose, that's the total dose, given in how much time you are given, what is the fraction size, and what is the volume of the tissue you are going to irradiate it, and that is the sensitizer and protector. All these decides you what should be the dose fractionation, the dose, time, volume, and fractionation. Very well, you know tumor control probability, that how the sigmoidal curve goes up, and you know that for tumor, is there any pointer? No. No pointer? Okay. So you know tumor and the late edema or the normal tissue reaction very well known. Now radiation therapy evolved as an empirical art, not an exact science initially. Clinical innovations and experience have consistently been followed by attempts to explain the underlying biology. And you know, last 20 years is a tremendous technological development. Earlier was understanding underlying radiobiology. Fractionation was introduced not because of an appreciation of the nuisance of radiobiology, but because the technological limitations of the early therapy machines meant that any treatment had to be given using interrupted regimes that we are not able to give continuously. Freud, in around 1910, treatment of a girl with hairy nevus was delivered in 10 daily fractions from the 24th November to 3rd December 1896, and that showed that those can be delivered in a fractionation. Once more, reliable equipment became available. Single fraction treatments were tried, initially again 1910, 1920, all those days. After 20 years of a clinical use, it became evident that the so-called therapia magna stellaris was clinically ineffective because of the underlying radiobiology, because that time the dose confirmation was not as accurate as today, because the integral dose or normal tissue irradiation was very high, and therefore the normal tissue reaction, normal tissue complication forced us to go from a single large fraction to daily fractionation. The most important lesson that history has taught us is that there can be no single regimen of treatment delivery that will be appropriate for all tumors in all patients. And therefore, it is the clinical judgment, it is the clinical evidence base that will show in a particular kind of tumor, particular site, what should be the dose fraction. It cannot be uniform for all kind of tumor, all kind of sites. Mathematical modeling without accurate clinical observation is an exercise that is both futile and dangerous. Fractionation cannot be considered in isolation. There is a complex interdependence between total dose, what we are going to give, dose per fraction, what we are going to try, overall treatment time, how much time over the time we are going to give, treatmented volume, how much it is there, and beam parameters, all will decide you what is the best fractionation modality in terms of tumor control probability and minimal tumor the normal tissue complication probability. Prescribing conventions and quality control procedure, there is of course nothing intrinsically unsafe about doses greater than 2 gray per fraction, but if alterations is not paid to, attention is not paid to these other details, then disasters can occur when higher dose per fractions are used. Clinical advances precede and are preceded by advances in our basic understanding of radiation biology. The tolerance of normal tissue to the late effect of radiation limits the dose that can safely be prescribed to the tumor. The tolerance dose varies between tissues and is influenced by the proportion of the organ treated and that the volume of the organ which you are going to take, V10, V20, V50, whatever you are going to take, influenced by the proportion of the organ treated, the length of the follow-up and the endpoint assessed, that will make you what is the tolerance dose. For some tissues, continuous function is impaired and by low dosage, while for others, necrosis occurring at higher doses is a critical event, and therefore one fractionation schedule cannot be applicable for all kind of tumors, all kind of biologically active disease. Dose volume relationship has been analyzed in detail in the radical radiography of actually the hypofractionation has actually started mostly with the lung cancer actually because of many problems. The percentage of total lung volume receiving excess of 20 gray was statistically significant predictor for the development of the grade 2 pneumonitis. If this value was less than 25%, then the dose escalation was considered acceptable. Higher values prompted revision of the radiotherapy plan and all fatal cases of the pneumonitis occurred in patients with V20 value exceeding 35% of the dose. As we move into the era of IMRT, what has driven us from again going to the hypofractionation or a single large fractionation is the IMRT, the technology, the accurate dose delivery into the tumor or the conformative index at which we are able to delineate the normal tissue, critical organ and targeting the tumor only. This has again brought in the hypofractionation or the single large fractionation. As we move into the era of IMRT, with unconstrained beam arrangement, these data may no longer be valid. What we have thought earlier, the V20 value has also been found useful in limiting the incidence of radiation pneumonitis in treatment with hypofractionation radiotherapy. Now, mathematical models, when you are talking about in radiobiological effect, radiobiological models can help to predict clinical outcomes when treatment parameters are altered. They have assumption that cell death after radiation connected in abrogation of cell production activity. At least the double strand break in DNA is responsible for cell death. That are some of the assumptions. Very well you know that initially 1940-45 NSD came, then after that CRE, then that CDF and all those things. But during 1980s, the LQ model has come up and that is very well nicely explained the various dose fractionation schedules early, late effects, and then we decided what fractionation schedule is best as far as the late effects are considered, or as far as early effects are considered, or effect of the tumor are considered. And this was being used for a very, very long time. LQ simple alpha d plus beta d square, this equation. But cell survival curves and the linear quadratic model, if you talk about the just I will show that if you come to the actually multiple fractionation, then the your curve will go away from that thing, and if the larger fractions are there, it will be shallow, it will come down, it will fall without any you can say the curve at the neck. Now all the dose fractionation depends upon the alpha by beta ratio. Alpha by beta ratio is the dose at which the linear component of the damage is equal to the quadratic component. Alpha by beta defines bending of the survival curve. If alpha by beta ratio is high, lethal damage or curve is linear at the origin. There is no what you can say the curve is directly coming down. You don't have the direct bending of the survival curve. Alpha by beta ratio is low, damage can be repaired, and curve with the shoulder at the beginning you can find it.
More points. 2 plus 2.
So where hypofractionation can be used? Alpha by beta ratio high, early responding normal tissues, proliferative tissue, skin, mucosa or bone marrow. Fast growing tumors, alpha by beta ratio low, late responding normal tissues, tissue not proliferating, they are kidney, liver, central nervous system. Slow growing tumors, alpha by beta ratio high, no fractionation sensitivity. If alpha by beta is high, fractions are 25 or 30 will not make much more difference. For example, most of the tumors which have got alpha by beta of 8, 10, the fraction number 25 or 30 will not make much more difference. But alpha by beta is low. For example, prostate, breast cancer, or for example, lung cancer. There actually the fraction number will have more impact on the late effects and also tumor control. And therefore, these are the areas, lung, prostate or breast, where you can use hypo or very large fractionation because alpha by beta is low. Now you know bed very well, that is a biologically effective dose. You know alpha by beta, you can choosing that thing, and then very well you know that for most of the tumors alpha by beta is 10, except the prostate or the lung or the breast, and for the late effect the alpha by beta are of the order of 2 to 3. Just let me go fast. Okay. Now small dose per fraction protects tissue with low alpha by beta. And that is the reason why we are going for the hypofractionation in case of tumors with low alpha by beta, because they protect the tissue. Ratio compared to tissue, high alpha by beta. And now this has been given fractionation sensitivity of different tumors in clinical setting that has been given. If the tumor fractionation sensitivity is low, alpha by beta ratio of higher than that of the late responding healthy tissue. And now you can see that moderate to high or high, that is the level 2 evidence of the therapeutic ratio equivalent to conventional schemes in CA breast or prostate, and there you can have a very large dose per fraction, few fraction in case of these where moderate to high or high tumor fractionation sensitivity is there. The function of the radiation biologist is to make the clinician think and work accordingly. The radiologic models guides how the fractionation or what dose per fraction should be there, how many fractionation should be there. Modeling is a very, very complex phenomenon because it takes biological assumption, mathematical expression, these are the input, and then mathematical manipulation, and then you have to have a clinical trial to compare this, and this is what is called the black box. And again you can see here, if single large fraction is there, there is no dose, it is a direct coming. But multiple fractions are there with the recovery, this thing, and the tumor, the survival fraction will be very high. Here survival fraction comes down with a single large fraction. With the late, Now in hypofractionation, what is the rationale for the hypofractionation? Hypofractionation seems to contradict with what we have learned from classical radiobiology, that the 4 R's of radiotherapy, or many a times when you shift to the hypo or single fractionation, simple LQ model fails to predict the thing. So you have to modify that thing, or you have to go to other models like